to be joined by Dr. Maggie Bublitz. She is an associate professor of OBGYN, of Psychiatry and Human Behavior, and of Medicine at the Warren Alpert Medical School at Brown University. She's also one of my former clinical supervisors, so I'm very happy to have her joining today. Dr. Bublitz received her PhD in clinical psychology from the University of British Columbia and completed her psychology internship and T32 fellowship at the cardiovascular behavioral medicine program at Brown Medical School. She is also a member of the Stress, Trauma, and Resilience COBRA and the Mindfulness Center at Brown. Dr. Bublitz is a clinician and a researcher with specialties in perinatal mental health and integrated behavioral health. She leads several NIH-funded research studies among pregnant and postpartum participants at risk for hypertensive disorders of pregnancy. And she was also selected as a global Fulbright scholar for the 2024-2025 cohort. So we're really pleased to have her joining us today and are working through our technical issues together. So I am still unfortunately not seeing your slides, Maggie.
Okay.
So let's think of another backup plan. Do you have like Dropbox or some other way I could download it?
Let me see if I can share my screen once my slides are pulled up. Because I think that if I share my whole screen, it might allow it.
Yeah, sometimes it'll work if you share the whole screen or if you upload the content to the Teams meeting. Either can work.
That didn't work. So I'm using Teams online.
Okay, and they're being treated.
Is there a way?
So can I send you, Maggie, my Gmail address and maybe they won't filter out the PowerPoint?
Yes.
I'm putting it in the chat. Everyone forget it. Please don't email me there.
Okay. All right, let's try that.
I got the slides.
Hooray.
Excellent. So I will pull them up and we'll get started in just a second. I guess it takes Penn Medicine about 5 minutes to accept a slide. So thanks for being patient, everyone. All right, can everyone see that?
Great. I can see it. So
Awesome.
Thanks, Becca, for helping out.
Sure.
All right. So this is annoying, Becca, but I'll just ask you to kind of advance as we go.
No problem. Just let me know
Okay.
and I'll pass it on.
All right. Well, thank you so much for having me. And it's really a treat to get to see you, Becca, and to get to speak to the research group at Penn. So as Becca mentioned, I'm an associate professor at the Department of Psychiatry and Human Behavior at Brown. And I'm going to be talking today about one of my areas of research, which is perinatal stress and pathways to adverse obstetric outcomes. Next slide. I have no conflicts of interest to declare. Next slide. So in my talk today, I'm going to be providing some background information about maternal morbidity and mortality in the United States and the links in the existent literature between prenatal stress and adverse obstetric outcomes. Then I'll talk about this area of research that I'm pursuing on mindfulness training as a potential intervention to disrupt stress pathways. So I'll provide a rationale for why we think this might be effective. I'll present the results of a pilot study, and then I'll talk about an ongoing RCT and present a little preliminary data from what we've collected so far, and then talk about where we're going next with this work. Next slide. So in this figure, you can see that the rates of maternal deaths in the United States has been increasing. So this presents data between 2018 and 2021. And rates of maternal deaths are going up across all racial and ethnic groups. You can see that rates are particularly high among non-Hispanic Black women. Next slide. Here you can also see that there are disparities in terms of hypertensive disorders, birth weight, and preterm delivery by race and ethnicity, with the green line showing data from 2007 to 2019 that non-Hispanic Black women have the highest rates of hypertensive disorders of pregnancy, low birth weight, and preterm delivery. And you can see that rates have been fairly stable in birth weight and preterm delivery, but have been increasing over time across groups in hypertensive disorders of pregnancy. I think there's a little animation there, Becca, and then you can go to the next slide. Thanks. So hypertensive disorders of pregnancy, I'll have you just click through all the buttons, are defined as preeclampsia, eclampsia, gestational hypertension, and chronic hypertension. And this is a little outdated, actually. The prevalence has increased, or recent data suggests that rates are even higher, but prevalence has been about 1 in 10 pregnancies in the United States. Morbidity associated with these disorders include placental abruption, seizures, organ failure, growth restriction in the fetus, premature delivery, and future cardiovascular disease risk for both the mother and the infant. And there's a high rate of recurrence. So up to 50% of women who experience a hypertensive disorder will have a recurrence in a subsequent pregnancy. Next slide. And you can click through these buttons as well. So current pharmacological treatments do exist for hypertensive disorders of pregnancy, and some antihypertensive medications can be taken safely in pregnancy to control blood pressure. Low-dose aspirin is also prescribed prophylactically for individuals who have had a prior pregnancy complicated by hypertensive disorders. And this needs to be started early in pregnancy and taken daily. So uptake and adherence can be a problem, and risk reduction is fairly modest. Non-pharmacological interventions include watchful waiting and early delivery. And the interventions that have been tested but not proven effective include physical activity, weight loss, vitamin intake, and diet changes. Next slide. So there have been a number of large meta-analyses linking the experiences of prenatal depression as well as depression and anxiety and increased risk for preeclampsia and hypertensive disorders. Why I present this data is that there's some evidence suggesting that maternal mental health may be a contributing factor in increasing risk for hypertensive disorders of pregnancy. Next slide. There's also data suggesting that it's not just sort of clinical diagnoses of prenatal and prenatal depression and anxiety, but also the experience of psychological stress. And in this meta-analysis, they define stress as experiencing a stressful event in the prenatal period. And that was also associated with adverse obstetric outcomes, including preterm birth, low birth weight, and small for gestational age. Next slide. And there are 2 animations on this slide. Thank you. So in this paper, in Seminars in Perinatology, Burris and Hacker proposed this model that may explain why we're observing these disparities in birth outcomes by race. And so they propose that there are a number of environmental as well as individual exposures that accumulate and lead to the kind of epidemiological evidence that I presented earlier. And so pathways include the experiences of psychosocial stress as well as discrimination. And I highlight these pathways in particular because these could potentially be targets for interventions to reduce the risk for hypertensive disorders as one of the adverse birth outcomes. Next slide. And can you click through those bullet points as well? Thank you. So mindfulness is a training that John Kabat-Zinn is credited for bringing to the West from the East. So it is a tradition that's thousands of years old, that is rooted in Buddhism and Hinduism. And John Kabat-Zinn was trained in mindfulness meditation by a number of teachers, one including Thich Nhat Hanh. And so in the 70s, he sort of brought his training and expertise and created a westernized version called mindfulness-based stress reduction. And the definition of mindfulness is awareness that arises through paying attention on purpose in the present moment non-judgmentally. And so now there is a large body of evidence on mindfulness-based stress reduction and a number of health outcomes and mental health outcomes as well. Next slide. So what do we know about mindfulness and blood pressure? There have been a few systematic reviews and meta-analyses in non-pregnant adults, and they found very similar outcomes, such that mindfulness training was associated with reduction in systolic blood pressure by 5 to 6 millimeters of mercury and diastolic blood pressure reduction by about 2.5 millimeters of mercury. In pregnancy, there's very little evidence testing mindfulness training as an intervention to reduce blood pressure. There has been a study, which I'll go into a little bit more in a few minutes, suggesting that trait-level mindfulness is associated with lower blood pressure. But no studies had been designed to assess the utility of mindfulness training for women at risk for hypertensive disorders of pregnancy. Next slide. There's evidence providing a rationale for why mindfulness training may be associated with reduced risk. So in this study, it was approximately, I think it was 34 women with microvascular angina who completed an 8-week mindfulness-based stress reduction course in addition to medication. And this was a single-arm study, and they assessed changes before and after mindfulness in terms of myocardial function and endothelial function, and found improvements following a mindfulness training 8-week course. Next slide. There is also a mindfulness clinical trial in healthy pregnant women, and this was 74 women who were randomized to a 5-week, twice-a-week mindfulness intervention, and the control group received usual care, and they assessed improvements in autonomic function. And the picture that you see here is the cold pressure test, where prior to the intervention, all women were asked to place one hand in a bucket of cold ice water up to their wrist, and on the other arm, they took the blood pressure of the participant and assessed change in blood pressure from baseline to the time of pain threshold. And they did that before and after the intervention. And they found that in the mindfulness participants, their systolic blood pressure change was lower following the intervention. However, both of these studies that I just mentioned were excluding, or the the last study that I mentioned with the cold pressure test excluded participants with hypertensive disorders. So we didn't yet know if mindfulness could be effective among women who were either hypertensive or at risk for hypertension. Next slide. So this is the paper that I mentioned earlier that evaluated trait levels of mindfulness and a number of cardiovascular parameters in pregnancy. And so the solid line here represents those with the highest level of trait mindfulness. So trait meaning that this was not a part of an intervention. And you can see in the red box that those with the highest levels of trait mindfulness showed that blood pressure between first and third trimesters that did not change or decreased over time relative to those who were less mindful on this measure. Next slide, please. This is a busy table, and it's sort of intentionally busy to show that there have been a number of prenatal mindfulness trials. However, and the results of this body of research indicate that mindfulness training is useful at reducing stress and symptoms of depression and anxiety in pregnancy, and also that these studies systematically excluded participants who had medical conditions or were at risk to develop medical conditions. So we know we can do mindfulness training in pregnancy. However, we don't know if it's feasible or effective in patients who are considered high risk. Next slide. So why wouldn't there have been previous studies of mindfulness-based stress reduction in pregnancy? So the gold standard mindfulness intervention, mindfulness-based stress reduction, is an 8-week program of group classes. And each week, the group meets for 2.5 hours at a time. It also includes a full day silent retreat, and participants are expected to practice the mindfulness exercises for 45 minutes a day. And when I was getting involved in this type of research, it was suggested to me that I take a mindfulness-based stress reduction class so I could learn more about the intervention and the delivery. And this, I was very motivated and had lots of support, and this was still very hard to adhere to. That it was a very significant time commitment. And so I thought for high-risk pregnant women who have a lot of medical appointments, this was really not going to be a feasible intervention. So I partnered with my colleague, Elena Salmorago-Blosher, who had developed a phone-delivered mindfulness training intervention that was comprised of the same principles of mindfulness-based stress reduction. And it was still an 8-week program, but each session, rather than 2.5 hours, was 30 minutes. And these were delivered individually over the phone with a certified mindfulness instructor. There was no silent retreat. Sorry, Becca. And then rather than 45 minutes of daily practice, it was reduced to 15 minutes. And this was initially developed for patients with implanted cardiac defibrillators. So it was a cardiovascular population. Next slide. So then we conducted this pilot study of a mindfulness, the phone-delivered mindfulness training intervention that was funded by the Mindfulness Center at Brown, as well as the Cardiopulmonary Vascular Biology Center of Biomedical Research Excellence, which is a mouthful. And this is a picture of my mentor, Gada Borgili, who has expertise in cardiovascular, adverse cardiovascular disease and disorder in pregnancy. Next slide. So the aims of this pilot study were to first test if the intervention was feasible and acceptable, next explore if there were changes in blood pressure across the intervention, and then explore if mindfulness training was associated with fetal growth, which is one of the consequences oftentimes of experiencing hypertension in pregnancy. Next slide. So this is a picture of Elena, who created the phone-based mindfulness intervention, and a table showing the 8 weeks and the different topics that are covered by session. So you can see there's a strong focus of awareness of breath. Next slide. And you can click through all of these animations too. Thank you. So, oops, sorry, went too far. So you can see here in this slide, there is a slight change in blood pressure over the course of gestation, where blood pressure dips slightly over the second trimester and then increases into third trimester. And so we intentionally timed our intervention such that we would try to prevent the increase of blood pressure between second and third trimester. So the red arrows indicate when we were collecting blood pressure. The blue box indicates when the mindfulness training intervention was delivered, and then we collected birth outcomes at delivery, the yellow arrow. Thanks, next slide. So you can see here our consort diagram. So we ended up enrolling 30 participants. These participants were included if they had a prior pregnancy that was affected by hypertension, given the high rate of recurrence. So we enrolled 30 participants who met inclusion criteria. One withdrew prior to randomization, so we ended up randomizing 29. And you can see 14 were in the treatment as usual condition, 15 in the mindfulness training condition, and 4 were lost to follow-up in mindfulness, and 1 lost to follow-up in treatment as usual. Next slide. Here you can see some demographic information across groups. So women were on average 33 years old. The race and ethnicity is presented here, primarily white and non-Hispanic. Body mass index was similar across groups. And then you can see at the bottom, if we look at GA at delivery and birth weight, there in the mindfulness group, while not statistically significant, we see that the mindfulness participants delivered about 2 weeks later than our treatment as usual participants, and birth weight was similar across groups. Next slide. Okay, and then in terms of our feasibility and acceptability outcomes, we defined mindfulness completion as attending 6 or more of the 8 sessions, and 73% of our sample did complete the intervention. And this is comparable to prior prenatal clinical trials of mindfulness in lower risk samples. 73% of participants also indicated that they were very satisfied in response to the question, rate your overall satisfaction with mindfulness training. Next slide. We collected in-office blood pressure. The initial intention for this study was to collect 24-hour blood pressure, but we conducted it over the pandemic. And so we needed to move to fully remote data collection, and we were able to extract blood pressure from their obstetric visits. And you can see the red line represents those who were in the mindfulness training condition. And before and after mindfulness, you can see that those in the mindfulness condition had lower diastolic and systolic blood pressure. And this was recently published. You can see the citation here. Next slide, please. We also found that rates of hypertensive disorders were lower in the mindfulness training group compared to treatment as usual. And if you recall from the beginning of the talk, there's about a 50% recurrence rate. So our treatment as usual group really kind of mirrored that. And those in the mindfulness training group seemed to have lower rates of recurrence. Next slide. We also extracted information from the medical record from the clinical ultrasounds. And we were interested in whether there was differences in trajectories of fetal growth over the course of the study by group. And these are all Z-scored. You can see that all values are above 0, indicating that all babies were of normal weight, so we didn't see growth restriction. But you do see a difference in pattern, such that the treatment as usual group seemed to be decreasing in terms of their growth from 18 weeks to birth. And the mindfulness training group is a little bit more stable, if not an upward trend. So we thought that was an interesting observation, something for future research. Next slide. We also collected quantitative and qualitative data in terms of some of the mental health symptoms. And we found that those in the mindfulness condition at follow-up reported lower scores on the perceived stress scale, lower depression, although that didn't reach statistical significance, lower anxiety, also not statistically significant, and higher levels of mindfulness. We also conducted qualitative interviews for all of our participants after they had completed the intervention or treatment as usual. And you can see some quotes here from the qualitative interviews that sort of add some color, I think, to what we see in our quantitative findings. So one participant said, if you catch your negative thoughts, you're able to calm the feeling that stress brings. It goes away. Another participant said, when I'm sad, I feel it literally in my chest. I imagine like vines wrapped around my rib cage, and then I imagine every time I inhale and exhale, I was letting the vines loosen up. One participant told us that since the study started, I haven't had any anxiety attacks. And then lastly, I'm able to be more aware of things that come to mind and not really push them away. Next slide. Participants also told us about effects of mindfulness on their interpersonal relationships. And this was a surprise to me, especially because this wasn't delivered in a group intervention. But you can see a number of participants here talked about how mindfulness was helpful in dealing with difficult and chaotic people. One participant said she was nicer to her husband. Another participant said that it helped their relationship, that she and her partner were kind of talking about emotions and awareness for the first time. And participants also mentioned impacts on their parenting and their ability to kind of be a more relaxed parent. Next slide. So conclusions and future directions from this pilot study. We found that this phone-delivered mindfulness training intervention was feasible and acceptable among high-risk pregnant women, and seemed to be associated with reductions in blood pressure and risk for hypertensive disorder recurrence, potentially increased fetal growth rate, and reduced psychological stress. So the next step was to ask, why was this intervention seemingly beneficial, particularly for cardiovascular health? Next slide. So that leads to the ongoing clinical trial, which is called the Mindfulness and Mechanism Study. And you can see here a diagram of the activities of this larger clinical trial. So in this ongoing study, we're in year 4 now. Participants are recruited who have a risk factor for hypertensive disorder of pregnancy, but not currently hypertensive. So they do not have elevated blood pressure at the time of enrollment. So a little bit different from the pilot study where they had to have a history of hypertension in a prior pregnancy. They're recruited between 15 and 18 weeks gestation. And at that point, they complete a 24-hour ambulatory blood pressure monitoring session. And they also complete a research ultrasound where we're measuring uterine artery Doppler, as well as a number of fetal growth measures. They then complete 2 weeks of ecological momentary assessment because we were interested in how the mindfulness training experience affects their sort of day-to-day responses to potential stressors in their environment. So in the 2-week EMA survey, they get 4 surveys a day between the hours of 9 a.m. and 9 p.m. And we ask them about their some of their psychological experiences throughout the day, interpersonal experiences throughout the day, and they're also connected. They wear a Garmin watch, which is connected to the EMA platform. So we're able to sort of couple their heart rate variability with some of the responses that they're providing on the survey. After they've completed all the baseline data collection, they're then randomized to 8 weeks of the phone-based mindfulness training or 8 weeks of usual care. And then we repeat all of those baseline measures again, and we follow them until delivery. Next slide. So the specific aims of this ongoing clinical trial are to evaluate the psychological, physiological, and interpersonal responses to daily experiences as mechanisms linking mindfulness training to cardiovascular parameters in pregnant women at risk for hypertensive disorders of pregnancy. Next slide. So to go into a little bit more detail about the methodology, so as I mentioned, women are wearing 24-hour blood pressure monitors, so we're able to collect information on their blood pressure both throughout the day and at night, as well as the change from day to night, which is called dipping, and that's predictive of the development of hypertension. And then we're also doing these research ultrasounds that measures uterine artery Doppler, and this is an indication of the health of the placenta. So using these two measures, these are our primary cardiovascular parameters as outcomes of the study. Next slide. Then I mentioned our EMA protocol. So this picture in the top right is Nicole Nugent, who's at Brown, who has a wealth of experience doing these types of daily measurements. So on the far left, you can see an example of the daily surveys that participants receive. The middle shows the Garmin watch that's connected to the, there goes my dog, that's connected to the surveys. And then on the far right is, you can see this woman who's wearing a phone kind of on the outside of her clothing. So in addition to asking participants about their interpersonal experiences throughout the day, we're also using what's called EAR, or electronically activated recorder. So we're having a phone collect 30-second recordings of ambient noise. It's about every 20 minutes throughout the day. And these will be coded for the kind of environment that the participant is in. So there's a coding rubric that allows our research assistants to code things like if the participant seems to be alone or with others. You can code things like if they're watching TV, if they're having a conversation with another person, if they're talking about the baby. And so we'll be able to kind of get a more objective picture of their environment using this methodology. Next slide. So this is a little outdated. We're further along now, but you can see in this consort diagram, our goal is to enroll 150 participants. We're actually at 130 now, so a little bit further. We have, what we've found is that we are retaining our participants quite well after randomization, and the biggest challenge has been to keep our participants following consent prior to randomization. I think because it's a pretty intensive protocol, and these are all participants who have a lot of other doctor's appointments. Next slide. So I wanted to present a little bit of preliminary data from this ongoing trial. In terms of some of the results that we've seen from baseline, we've seen that a mindfulness measure of interoception, or kind of body awareness, is associated with 24-hour diastolic blood pressure. So higher kind of interoception, or awareness of one's body, is associated with lower blood pressure. We see a similar pattern when we look at our ultrasound data, where we're looking at a marker of kind of placental sufficiency. And we're also seeing that in terms of some of our birth outcomes, we are, it is a higher risk sample, so we are seeing fairly high rates of gestational hypertension, about what we'd expect to see in terms of preeclampsia, a little bit, well, pretty much consistent with our state data in terms of preterm birth and gestational diabetes. Next slide. So these I pasted into the talk like 15 minutes ago. So these are very hot off the press. But to kind of go full circle back to the maternal mortality data that I presented at the very beginning, the ultimate goal here is to try to prevent hypertensive disorders of pregnancy, but particularly trying to reduce the racial disparities that we're seeing in maternal morbidity and mortality. And so this is just some descriptive data from the participants that we've run so far, but I'll walk you through it. So on the left, what I'm showing here is the change in blood pressure before and after the intervention, and this is specifically systolic blood pressure during the day. The red lines represent participants who are randomized to mindfulness, and the black lines are participants randomized to treatment as usual. And the solid lines are participants who self-identified their race as Black. And the dotted lines are those who self-identified their race as other than Black. So you can see on the left, what we're noticing is that mindfulness overall seems to be associated with lower blood pressure, but it may be particularly beneficial among our participants who self-identify their race as Black. And then on the right, this data is showing their pregnancy-specific anxiety. And we also see that the solid red line are participants who self-identify their race as Black, and they're telling us that their anxiety is decreasing from enrollment to after the mindfulness intervention, and they seem to be particularly benefiting from the training. Next slide. So given some of the promising preliminary results, we applied for an ancillary R01. So this is a R01 that kind of builds upon the clinical trial that is ongoing. So you can see on the right-hand side of the slide, the additional study visits that will occur as part of this R01 that will go until 2029. So we will continue to follow the 150 participants as well as their infants at 4, 6, and 12 months postpartum. And we're going to repeat that same 2 weeks of ecological momentary assessment where we're measuring their psychological, physiological, and interpersonal daily experiences. And then at each time point, we're also going to be collecting 24-hour blood pressure in the mom, as well as some, we'll do a blood draw to collect some lab values as cardiovascular disease biomarkers. And then in terms of the infant's cardiovascular health, what I've learned by working with pediatricians is that we don't really take blood pressure in infants. And the way to approximate their cardiovascular risk is by measuring their growth over the first year. So we're requesting pediatrician records to look at growth velocity over time. And next slide. So stay tuned. There will be hopefully lots of interesting results coming out of these 2 studies. Next slide. So that is all of the information that I'm presenting today, but I invite questions. I apologize again for my camera being off. That isn't my face on the right, but that is the face that I make when I collaborate with other people and write papers. So I really do love collaborating, and if there's any kind of parts of this study that you find particularly interesting and would like to speak with me about, there's my email. There's going to be more data, I think, than I will ever be able to look at. So rising tides lift all boats, and I'd love to kind of get this information out there. And I think I have one more slide, which is my thanks. So thanks to my mentors and collaborators, my funding sources, and my wonderful team. I'm happy to take questions.
Thank you so much for the amazing talk and very exciting data. I'm going to open the floor for questions, right? So folks can feel free to unmute and chime in, or if you want to put some stuff in the chat, I'm happy to read it. Looks like Ray has his hand raised. Do you want to go ahead?
Yeah, I do have this is amazing study, and I like we have more research to support some of the interventions we psychologists can provide in medical settings. But my first question will be, do we like measure like the long-term like health benefits like post-pregnancy? Like does benefits of mindfulness intervention, whether it's about reducing the risk of hypertensive disorders, blood pressure, and also reduction of stress, like does that still maintains post-pregnancy?
That is a great question. That is one of the key questions that we have with the ancillary study. So we will continue following participants for the first year postpartum. There is some evidence in the literature that the effects do last after mindfulness training, but may fade slightly. And of course, if people continue to practice regularly, they're more likely to continue benefiting from the intervention. But I'm also working with a woman who, her name's Mish Anderson, and she's writing a K Award where she would like to kind of add another time point. So looking even further down the road at around 2 years old, and also kind of doing a mother and baby task to see about sort of coupling of cardiovascular responsiveness to a stress task, and whether we can see any differences in both the moms and the babies further down the road.
And definitely, the reason why I asked this question is, given the qualitative data you presented on one of the slides, it looks like, many patient in the treatment group did find mindfulness intervention to be helpful. And I'm just thinking maybe from a learning perspective, there's people under a lot of stress and they use this strategy and find it helpful to reduce stress. Maybe it's more likely for them to practice this even post pregnancy, and maybe the behaviors will stick with them. But I'm also curious, like, do we like control for initial levels of trained mindfulness?
That's a great question. And I should have mentioned that one of our inclusion criteria is that participants haven't been engaging in mindfulness. So these are all kind of naive meditators.
I see.
So we do collect baseline levels of mindfulness, and there's definitely variability in sort of trait levels of mindfulness, but none of our participants have undergone kind of a formal mindfulness training program before.
And post the 8 weeks training, do we know there's any changes in their levels of trained mindfulness?
We will. We're collecting it.
Awesome.
Yeah. So we'll have a lot of that data to look at.
Thank you.
Thanks.
Those are great questions. I have a clinical applications question, Dr. Bublitz. So I'm noticing the amazing ease of access to a training like this that's delivered by phone. That's 8 weeks. That like really creates the possibility for folks to be able to participate in this type of training. And I'm curious, knowing that some of your clinical work is in integrated behavioral health settings focused on women's health, if there's hopes to translate mindfulness-based training to medical practices, like when women are at their appointments or already getting care. What are your thoughts on that?
I'm so happy that you asked that question, because I have many thoughts on that. One of the integrated behavioral health services that we have at Brown is embedded into the OBGYN office. And so where I'm hoping to go with all of this work is to get to a point where as a provider is prescribing low-dose aspirin, they are also prescribing mindfulness. And that just becomes like a pairing that becomes sort of second nature to our providers. And so I'd like to go in the direction of sort of a hybrid type 2 implementation effectiveness type trial. I think one of the hurdles will be, as it always seems to be, billing. So currently, if they were not in the study, people pay quite a bit for mindfulness training interventions, hundreds of dollars, and that's a real barrier. And I think there's some work happening at the Mindfulness Center at Brown with insurance companies to try to advocate for reimbursement. At this point, one can be reimbursed for mindfulness if you're like a trained psychologist, but our mindfulness instructors aren't all trained or credentialed with insurance companies. So that is something that I'm still pondering. But I think if after all of this we see that there's sustained benefit, it seems like that I would hope to be able to disseminate it in that way.
Yeah, thanks for that answer. And that's something for us all to think about, right? That perhaps there's easier reimbursement for psychologists sometimes than for other professions, which is challenging for access. Other questions from folks? While people think, I'll throw out a question that I've been asking many of our speakers, which is that if you could fund any study or create any change in clinical access or programming, like what would be your magic wish for the application of this work?
Can you say that one more time?
Sure. So if you had like a magic wand and could change something about healthcare systems or about access to care or create an application for this work, what would you hope to see?
So I just spent 2 months in the UK as part of my Fulbright. And so this is truly a magic wand because I know I can't translate what I saw there to the US easily. But I think the national health system to me was, it just removed so many barriers to care that we have in the US and really focused on patients and prevention. And it seems like there's just such a huge focus in healthcare on billing and volume. So of course, I'd like to, I could give a specific answer about mindfulness training, but I think my experiences there taught me that you can't sort of change one aspect of healthcare without having kind of ripple effects. And I think if things change for the better, I think they need to happen at a much higher level, like at a policy level.
That's a great answer. What other questions do folks have? I'll ask another one because people are being shy today. Dr. Bublitz, I'm curious about the multidisciplinary nature of this work, that it seems like you have collaborators that, are cardiovascular experts that are likely, in OBGYN practices as, providers or ancillary staff. And I'm curious what has created this multidisciplinary environment for your work and what kinds of recommendations you would have for our psychologists about building that multidisciplinary collaboration.
Thank you. Yes, my work is very multidisciplinary. And I think from being at Brown for some of your training that the group that I'm a part of that has changed recently, but it was called the Women's Medicine Collaborative. And the focus of really the whole clinic was multidisciplinary collaboration. And thankfully, I got introduced to some really wonderful colleagues who introduced me to more wonderful colleagues and really facilitated the team-based approach that we're using. Advice-wise, what I've been continuously surprised by is just people's willingness to respond to an email, even if they don't know you. This also comes out of my Fulbright work, which was completely emailing people from other parts of the world and seeing if they'd be willing to kind of go through this experience with me, and they were generous with their time. So I think if you're enthusiastic about an idea and there's traction, that this could be good for everyone and good for patients, then people will want to work with you.
I love that. So we should keep knocking on doors.
We really should. And even if they're like, if it's sort of in an electronic way, it doesn't have to be that you actually know them. It can just be an email with, yeah, sort of enthusiasm for an idea. And it's always helpful if you can get introduced by someone who does actually know the person.
Good sense. All right, anyone feeling brave? Faith, yes, please.
Sorry, it's actually me. But I had a quick question because as you were going through the slides and talking about kind of doing mindfulness, initially 45 minutes and then doing 15 minutes, I was getting overwhelmed thinking of like being the patient because mindfulness for me is very difficult. So I'm wondering how you navigate, some of the people who are maybe more resistant to mindfulness or have a tougher time engaging in mindfulness, especially over the phone when you can maybe miss some nonverbal cues that you might be able to see over something like Zoom or in person.
Right. Yeah, thank you. That's a great question. So I'm not one of the mindfulness instructors. I wish we had our mindfulness instructors here to answer that question for you. One of the, I think the benefits of having a one-on-one session is, I think a lot of what is talked about in the sessions is troubleshooting and is talking about the challenge of mindfulness is not easy. It's not easy for anyone. It's a learned skill. And our qualitative data are totally what you're describing, that initially there's reluctance, resistance, skepticism. Our participants have said like, it sort of conjures up these ideas of like sitting on a pillow and wearing like stretchy pants, and that's not who I am. And I think that while of course some people do self-select to not complete the full intervention, after establishing, I think, rapport and a relationship with the instructors and being willing to get through the first session, we almost find that our attendance is bimodal. Either our participants go to one session and decide, no, this isn't for me, or they do really all the sessions because they find some benefit from it. I'm not sure if that exactly answers your question, but I think that our instructors are skillful in kind of meeting participants where they're at, not saying, you must do this, you must do it this one way for it to be helpful, but rather saying, it totally is tough. Like, tell me what's hard about it, and trying to kind of problem solve with them. We also asked our participants if they would prefer a video visit, and they overwhelmingly said no. They wanted to sit around in their like scuzzy hoodie and not have anybody look at them, and they liked the flexibility of a phone visit. And sometimes they're lying down, they have their eyes closed, so I think they felt more self-conscious doing that on a video visit.
That's really interesting. Thank you for sharing that. I wonder if that helped them become even more mindful when they don't have someone staring at them.
Possibly.
Thank you. It looks like we have time for one more question. Perinatal, go ahead.
So I haven't fully thought out my question yet, but I noticed that in this study, I wasn't sure if it was this study or the previous study, but the race, it was predominantly, I believe, white female, non-Hispanic. But I also noticed that when looking at the results, that there was a significant impact for the Black women as to the levels of the hypertension that they were experiencing. And knowing that the maternal mortality death rate is significantly higher amongst Black women, I'm just wondering, has there been any thought as to how this study might be able to kind of guide treatment going forward for Black women?
Yes, thank you for saying that. So in the pilot study, we didn't have, I would say, appropriate diversity. For our ongoing clinical trial, that was one of our goals, that we specifically aimed to recruit a more diverse sample. And that was really necessary to be able to probe some of these questions. Data that I didn't present here includes, so we received an administrative supplement where we conducted qualitative interviews with our Black and Latina participants who were randomized to mindfulness training, because we wanted to know, is this intervention fitting with how you want the intervention to be? What modifications would you recommend? And they gave us really great information about terminology, education, and recruitment opportunities. They really wanted the messaging to get out more about, this is an intervention that is beneficial and people should know about it, and women should be pursuing it. They had recommendations about wanting to have kind of a peer support group. They'd like to connect with other, particularly Black women who are also pregnant and who are also going through mindfulness training, so they could talk about their experiences together. And so the next step in this sort of arc of research for me is to take the feedback that we received from that qualitative study and then create kind of an adapted version based on the feedback that we think, given that we're seeing some particularly strong benefit for Black women, we want to make sure that future iterations of the intervention are culturally congruent. So I work with a woman who's at Spelman College in Georgia who modifies mindfulness interventions for Black women. So we're working on this application. I hope it would get funded, but application together to sort of move this work in that direction. I hope that answered your question.
Yes, thank you.
Okay, well, that was a wonderful last question. And thank you again, Dr. Bublitz, for joining us today. This was such a wonderful body of work, and we're excited to see where it goes.
Well, thank you for having me. I'd love to come back at some point and tell you how it goes.
Yes, I would love that too. I'll have to invite you back soon.
Thank you. And sorry again about my technical difficulties. I'll hopefully sort that out also.
Yeah, no problem. Thanks everyone for joining.
Thank you. Bye.
Bye.